Welcome to this two-part Psych Education Session. Keeping in mind, many new residents start at the hospital July 1st each year to begin their residency program training. Today's session is certainly for this group. This 10-minute Part 1 session will show the documentation elements and guidelines of hospital E&M services. Then we will discuss in detail outpatient E&M CPT codes and their prolong codes. We will conclude with the Medicare Claims Processing Manual as our main resource.
Hi, I'm Julie, your Coding Education Specialist. Thank you for joining me today for this Psych Coding Education Session. Let's get started. As of 2021, the Outpatient Evaluation and Management Documentation Guidelines changed. We will discuss those documentation elements as well as documentation guidelines for both inpatient and outpatient E&M services. We will also discuss common psych CPTs and specifying diagnosis codes to the fullest. Inpatient codes 99221 to 99223 are for initial visits. You must meet 3 of the 3 components for history, exam, and MDM. 99231 to 99233 are for subsequent visits. You must meet 2 of the 3 components for history, exam, and MDM. If the patient is intubated or you're unable to obtain the history of performing exam, you must document why you weren't able to obtain it in order to bill services out. For family history, don't write non-contributory only. Put what you reviewed to avoid getting brought down from a level 3 to a level 1 because of missing family history. For these inpatient services, if billing by time, you must document the total time spent in the visit. It must be greater than 50% of total visit spent counseling and coordinating care, and content of counseling and coordination of care. Consult requirements: you must list the referring physician, provide service, history, exam, MDM, and have communication back to the referring physician. If insurance does not cover the consultation code, we will convert it to the subsequent visit on the back end. As we continue to discuss these inpatient services and the documentation requirements, I want to be sure I address that these are not for PhDs to bill out. Those will have separate psych CPTs, and we will discuss them in Part 2. This is the 95 and 97 guidelines for inpatient services. All your patient encounters will have a chief complaint. This will be in the patient's own words. It cannot be follow-up. It can be follow-up for depression. You will elaborate on it as it relates to the history of present illness. The review of systems are questions asked of the patient, and your documentation should reflect the patient's responses. PFISH. Document accordingly as it relates to the chief complaint. The documentation for the exam is the findings from your visual, touching, and listening to the patient. Final, your medical decision-making is your thought process of the assessment and plan of care for the patient. For your outpatient services, the first item to notice is if your patient is new or established. If the patient has been seen by the clinic for the last 3 years, they are considered a new patient. It is important because your CPT code selection is based off whether they're new or established. Let's take a look at the table published by the AMA. The American Psychiatric Association, under the Elements of Medical Decision Making, have provided some examples specific to psych in red for educational purposes. According to the AMA, medical decision making includes establishing a diagnosis, assessing a status of a condition, and/or selecting a management option. The MDM components are number of diagnoses, data, and risk. To determine the level, you would choose from 2 of the 3 columns. For straightforward, you would select 99202 or 99212. An example would be bereavement. If a patient came in today and has recently experienced the loss of a loved one or the loss of a spouse in a recent divorce, this single self-limited or minor problem, no data, and minimal risk would determine the straightforward visit. For the levels 99203 and 99213, this would be a medical decision making of low complexity. This would be for a patient if you prescribe over-the-counter medications because they can't sleep. Due to this acute illness and low risk because it's over-the-counter medications, that would make it a 99203 or 213. For one stable chronic condition, major depressive disorder, recurrent in remission, or for one acute uncomplicated illness or injury, an example would be adjustment disorder with depressed mood. For risk, an example for a low level would be a new patient seen for adjustment disorder and referred to a therapist. Here, the diagnosis component is basically the same. You list all the diagnoses you are monitoring, evaluating, and assessing, and/or treating. Even if you recommend a medication and they don't take it, you still get credit under the prescription management as long as it's documented. An example of a moderate level would be if a patient has 2 or more stable chronic conditions and you provide prescription drug management. You must document what the prescriptions are that you manage or any prescriptions that you made changes to. 1 or more chronic illnesses with exacerbation, progression, or side effects from treatment would be major depressive disorder, recurrent, moderate. For moderate risk, it will count if you document the limited social determinants of health, such as homelessness. We will be able to add one of the new diagnosis codes to justify moderate risk. For a high diagnosis level, suicidal ideations fall into this category. For the risk level, you will occasionally send patients to be admitted from a clinic. Those patients will fall into this category too. Patients that are having severe exacerbation of the chronic illness and need to be hospitalized. Here's an example of a 99215. We have a patient with one acute chronic illness or injury that poses threat to life, along with decision to admit. Now let's discuss billing by time. For example, when reporting an E&M based on time, factors other than face-to-face time with the patient may be taken into consideration, such as reviewing tests, as long as it's done within the same day. Here you see the prolonged visit codes. Remember, you can't bill 2 time-based codes together. Listed here are items that can be counted towards a time component. Remember, they must be performed on the same calendar date as the face-to-face visit with the patient. As you can see, this includes non-face-to-face activities too. Preparing to see the patient, reviewing their records or tests, obtaining and reviewing separately obtained history, performing a medically appropriate history exam evaluation, counseling and educating patient, family, or caregiver, ordering prescription medications, tests, or procedures, referring and communicating with other healthcare professionals not separately reported, documenting clinical information in the EHR, independently interpreting tests not separately reported, communicating results to the family, patient, or caregiver, care coordination not separately reported. Reminders, E&M 2021 changes only apply to codes
99202
to 99205, 99211 to 99215. Consultation requirements: you request, you list the referring physician, you render the service, the history exam, medical decision making, and communication back to the referring physician. The primary care exception rule is addressed in the Medicare Claims Processing Manual. Most of the teaching physician rules are in this manual. These rules allow residents to provide services to patients and bill for those services with low-level E&M services. Since January 1st, 2022, residents may independently see patients under the primary care exception rule. We are under the public health emergency extension of the rules.
This concludes part 1 of this 2-part series. Remember, you are valued and we are in this together. This is your Decluttering Dancing Coding Mom, where we declutter, dance, and code together.